Good evening, everyone. We're going to get started. Welcome to Science Café. My name is Jenny King, and I lead the UT Southwestern Public Affairs team and our UT Southwestern Science Café series, along with Charlie Thompson. On behalf of my colleagues here this evening, including Lori Enright, as well as our guest faculty speakers, Dr. Nitin Jain and Dr. Donald Kasitinon, thank you so much for joining us tonight. Science Cafés are online conversations where our speakers take you on deep dives into the science of healthcare. As an academic medical center, UT Southwestern brings together research, health education, and patient care into one institution. This evening, we are closing out the fall series with a discussion about non-surgical treatments for sports injuries and other musculoskeletal conditions. And before we get started with our speakers, I have a few items to share. We are recording this program and live streaming it on our UT Southwestern Twitter page. We ask you to mute your microphones to help with audio clarity for all. And we encourage you to leave on your camera so we can see each other, and most especially during the Q&A portion of our program. And finally, just a reminder, while we cannot answer personal medical questions, we absolutely welcome your general questions about tonight's topic of non-surgical approaches and treatment options to sports and other injuries. Please list those questions in the chat. Charlie will be addressing them after the conclusion of our presentations. And now I am pleased to introduce our faculty speakers, and Charlie will be putting bio links into the chat. Dr. Nitin Jain is a professor of physical medicine and rehabilitation, orthopedic surgery, and population and data sciences here at UT Southwestern Medical Center. He serves as vice chair of the Department of Physical Medicine and Rehabilitation, which we commonly refer to as PM&R, and chief of the section of Musculoskeletal in sports medicine, and director of outcomes research for the Department of Orthopaedic Surgery. As sports medicine specialist, he is an expert at treating non-surgical disorders of the shoulder and knee. Dr. Jain earned his medical degree at the Baroda Medical College in India, following a research fellowship in sports medicine and orthopedics at Duke University and a research fellowship in epidemiology and outcomes at Brigham and Women's Hospital. He completed a residency in PM&R at Spalding Rehab Hospital, Harvard Medical School. He received advanced training in shoulder surgery through a fellowship at the Harvard Shoulder Service. He also holds a master's degree in public health from the University of North Carolina at Chapel Hill. Dr. Jain's clinical and research interests include shoulder pain and rotator cuff tears, knee pain, regenerative medicine, and platelet-rich plasma therapies, ultrasound-guided injections for pain relief, and sports medicine. Certified by the American Board of Physical Medicine and Rehabilitation, Dr. Jain joined the UT Southwestern faculty in 2020. Next is Dr. Jain's colleague, Dr. Donald Kasitinon. Dr. Kasitinon is an assistant professor in the Department of PM&R at UT Southwestern. He's also associate director for PM&R residency and director of adaptive sports medicine program. He specializes in treating musculoskeletal and sports injuries and earned his medical degree here at UT Southwestern Medical School. He completed a residency in PM&R at UT Southwestern as well, where he also served as academic chief resident. He then received advanced training through a non-operative sports medicine fellowship at Stanford University Medical Center. Board certified in both sports medicine and physical medicine and rehabilitation by the American Board of PM&R, he joined our faculty in 2021. As a former competitive athlete in tennis, Dr. Kasitinon understands the importance of sports and movement. He enjoys all aspects of sports medicine, but his primary clinical interests include musculoskeletal ultrasound, team and event coverage, especially basketball, football, and tennis, adaptive sports, chronic overuse injuries of the elbow and shoulder, and regenerative orthobiologic therapies such as platelet-rich plasma. He also has a strong interest in medical education and is involved in teaching and mentoring medical students, residents, and fellows. Welcome to you both. Dr. Jain, the virtual podium is yours.
Thank you for that generous introduction. I'm just going to go ahead and share my screen here. Okay, I just want to make sure, can you see my presentation?
Not quite yet. I feel like it's about to pop up on the screen. It says you've started screen sharing. There we go.
Okay. Well, so welcome everyone. Thank you for joining us this evening. I'm sorry, did I lose you for a second? Okay, I'm going to
Yes,
start.
sir.
Again. I think something happened here.
We're okay. This is live TV, not really TV, but you know, we're just going to go with it.
Okay. Can you see my screen now?
It's coming. It's not there yet. There we go.
Okay. I just want to make sure I'm still visible.
We can see you and we can see your screen.
Okay, perfect. I'm sorry, I think Zoom is going in and out on me. I'm not sure why. Let me try one more time. If this doesn't work, I'll have Donald do his part, and then I'll try to log in again into Zoom.
And Dr. Jain, I can also pull up your presentation if that's helpful. Why don't you try one more time?
Okay, sounds good. So I have just shared my.
There you go.
Okay, but it's giving me an error message, I'm guessing. Okay. Well, I'm going to try this and see if this works. So apologies for the technical issues, but thank you everyone for joining us this evening. Dr. Kasitinon and myself will be talking about non-surgical treatments for sports and musculoskeletal disorders. And not only just non-surgical treatments, but we'll also briefly touch on the decisions that patients with musculoskeletal issues face in terms of operative versus non-operative management. So we just have a few questions to poll questions start off with. I promise these are not meant to be trick questions. These are simply to engage our audience. And if you can see the first question on the screen, I'll just read it out to you, which is, what type of treatment do most musculoskeletal and sports injuries require?
And Dr. Jain, folks are answering that question on the screen. I don't know if you can see that.
I sure can. And am I the one who's to end the poll?
I'm going to end it, and then you'll see, you can say, oh, that's what I expected, or tell us what you think.
Sure.
Okay.
Okay, so we do have a fairly informed audience where 85% of our audience is non-surgical, which is accurate. That's what most musculoskeletal and sports injuries require in terms of treatment. I do have another question, and I'll go on to the next question.
And that should be on everyone's screen.
So this is a question about who would be, and this assumes that you've already seen your primary care physician, because we are really talking about specialists. So similar to how you would see a cardiologist for a heart issue as an initial point of contact, who is a patient's initial specialty doctor for musculoskeletal or sports issues? And as you will notice, I did not put primary care physicians on there. Okay, so I like this answer where we have a fair split amongst those that say they'd see a physiatrist or a physical medicine rehab doc in an orthopedic surgeon. Now, to further complicate it, there are other non-operative musculoskeletal providers where those can be trained, have primary specialties in other areas, but they are referred to as non-operative musculoskeletal or sports providers, and physical medicine and rehab is one of those primary specialties. So I am intrigued by the fact that almost half of you say you'd see an orthopedic surgeon, which certainly is the case. And I'd like for the audience to think about it for a second, which is, would you see a cardiothoracic surgeon as your initial point of contact if you had chest pain or if you had a heart issue? You would usually see a cardiologist. Unfortunately, sometimes that's not the case, where orthopedic surgeons obviously are trained in musculoskeletal issues, but they are surgeons by nature, where their principal interest is surgery. And physiatrists or physical medicine rehab physicians are trained in musculoskeletal and sports medicine, but we do not do surgery. We do some non-operative procedures, but we do not do surgery. So with that, I'll move on to our next slide. The first thing I always ask when I'm presenting is, why do we really care about something? Why is this important? And musculoskeletal and sports issues, I challenge you, are one of the most common reasons why patients see their doctors. This is data. I present this graph. This is from the National Ambulatory Survey. This is done biannually in the United States. It stopped in 2016. But if we look at why patients see their doctors, period. So this could be patients seeing their primary care doctors. This could be patients seeing a physiatrist or an orthopedist or any kind of doctor. And what is their principal presenting complaint? Shoulder pain, back pain, and knee pain are the top 3 of the top 15 reasons why patients see their doctors. So in the year 2015-16, and this remains fairly consistent, about 12 million patients saw their physicians in ambulatory care settings with the principal complaint being knee pain. About 10 million patients saw their doctors with their principal complaint being shoulder pain. And back pain is probably these 2 added. So if I had to add shoulder, knee, and back, or even shoulder, knee, and hip, this is more than the number of patients that see their doctors for either common cold, pneumonia, or just a general physical exam. So musculoskeletal issues are a big problem. And more likely than not, each one of us will have more than one musculoskeletal or sports issue in our lifetime. One of the reasons that it doesn't get so much attention is the mortality from musculoskeletal issues isn't that high as compared to cardiac issues, for example, or respiratory issues. However, if we survey patients, and this is again data that's been published, patients that have shoulder pain or knee pain, the impact of those disorders on their quality of life, or what we refer to as morbidity, is similar to heart disease or diabetes or some of these other disorders that we think of as chronic. So although there may not be as much mortality as there is from cardiovascular disease or cancer, musculoskeletal issues, the other way to say it is, it really makes us miserable. We are in a lot of pain, and it really affects our quality of life. So that's why we care about these, and that's why these are important. Now, the other common misconception, and I try to put cowboys on here, and I think one of them is, but I think it says Giants. But anyways, I was a transplant from the Northeast. So one of the other misconceptions is, well, musculoskeletal disorders or sports injuries, as we refer to them as, happen in athletes, happen in professional athletes or athletes. They're not a common man issue. Well, I challenge you for that. The majority of people who have musculoskeletal disorders are people like you and me. So 90% of skeletal issues happen in people like you and me. And in fact, all
Okay, hold on. He's frozen. Charlie, will you please text Dr. Jain and tell him to turn off his video and turn it back on? And then if it doesn't work, Dr. Kasitinon, you're on in the hot seat, and I'm going to pull up his slides for you. Oh, here he is. He's back. Okay, Dr. Jain, are you back?
I'm back. I'm not sure why Zoom is giving me a hard time. This is the first time this happened, and obviously it happens during a live feed.
Right.
So let me just again.
Why don't I share my screen for you? Would that be good?
That'd be great, actually. That'd be awesome.
Okay. Y'all bear with me because let me start the slideshow from the beginning and share my screen. I want to pick the right screen. Share from the beginning. Okay. There we go.
Perfect. So again, apologies for these technical issues, but I was saying one of the common misconceptions is these are really injuries in the athletes. And next slide, please. And really, the most common folks in which it happens is people that are on this call and people like me. In fact, 90% of the patients, or more than 90% of the patients that we see in our clinics are really just regular folks, not athletes, not professional athletes. And even those that actually are team doctors, are professional team doctors, most of the patients that are seen in such clinics are really regular folks. So musculoskeletal disorders is not as a result of a sport injury. In most cases, these are just regular wear and tear. Next slide, please. The most common reasons for musculoskeletal and sports disorders are degenerative disorders. So this is just normal wear and tear. Normal wear and tear of our tendons, our bones, and our cartilage. The second is traumatic. Now, that's a minority of patients, but yes, there are traumatic issues. Someone hits, collides while playing football, or someone, there's an assault injury, or someone just falls down. Those are all traumatic injuries. Other factors such as genetic factors. So we do know that there's some evidence that genetics plays a role here, as well as the biggest bucket of this is the reasons for musculoskeletal disorders and why this happens is really unknown. What is actually the changes that are happening at the tissue level? And I'll get into some of that in my presentation. Next slide, please. So the next topic really here is surgical versus non-surgical management. And although this talk is more about the non-operative measures, we do face these decisions every day. Should we have surgery for this disorder, or should we not have surgery? So I'll present to you some data that kind of clarifies this issue. For almost, this is a study we did, which was published in JAMA Open, and we looked at arthroscopy rates in the United States in different states. Now, so this compares Texas to Massachusetts to Colorado to, I don't think there are all 50 states represented here, just because not all 50 states share this data. But there's a number of states in this graph. And what I'm trying to, the message here is that there's a large variation in the rates of arthroscopy across states in the United States. And now there is no reason why more patients or a higher proportion of patients should be operated in Texas versus in Massachusetts. There is just no reason for it, right? These are the same patients. And so, yes, there are some differences in population demographics by maybe age, by maybe occupation. There are some more rural states where there may be more farmers. And so, they may need to get back to work quickly. So in those cases, I can imagine that they might go for surgery sooner. But that's kind of small differences. In general, we would expect that the rates of arthroscopy or the number of patients or the proportion of patients that need surgical intervention should be similar across states if these indications are standardized. Now, I want to draw your attention to this graph. There are three graphs here. The two on the left-hand side show knee arthroscopy rates, and the bottom one on the left-hand side shows shoulder arthroscopy. The one on the right-hand side shows rotator cuff repairs. These are the three most common arthroscopic or ambulatory surgeries done in the United States. In fact, actually, we do about over 1.5 million of these surgeries every single year in the US, about 1 to 1.5 million. So more likely than not, someone has actually had this done. The dots on these graphs represent different states. The x-axis is simply the years. So you could just pick any year. Let's say we pick 2016, which is the far right-hand corner. The x-axis here represents the rate of procedure per 100,000 patients. So I just want to you to pay attention to the wide dispersion in the dots. So just pick any year, let's say 2016 for knee arthroscopy, which is the graph on the top left. Look at the orange dot versus the green dot. The orange dot falls around 180 procedures per 100,000 patients. The green dot falls around 450. So it's almost three times difference. And in some of these states, there's almost a 4 to 5 to 6-fold difference between states. So why do we have this variation? It's not as if the populations are drastically different, or for some reason, the indications for surgery are different in Massachusetts or Colorado versus Texas. This is simply a lack of standardization of these indications for surgery. That's really the driving point here. Next slide, please. So what I do encourage you, again, this is not meant to be a comprehensive, overview of all of the surgical and non-surgical indications, but really from the time that I have, I'm simply presenting some of the highlights. And so it's a really critical and difficult decision that is faced by most patients is, should I have surgery or should I have non-operative treatment? And I would say except for few cases, in most cases, musculoskeletal or sports injuries can be treated non-operatively. In almost all cases, in most cases, I would say. And I encourage you to really ask questions. I encourage you to ask questions to your physicians or to yourself as to why should you choose one path versus another? And is there enough evidence to support that? And have you really tried or maxed out on all of the non-operative measures? And even if you have, what is the data that the surgical procedure will yield any better outcomes? In certain cases, they do, and they're appropriate, but in many cases, they don't. Next slide, please. Now, just kind of going over what are some of the common non-operative treatments. Again, this is just meant to be the surface, and I'm simply giving a list of treatments. It's really not meant to go in depth. But some of the most common non-operative treatments are rehabilitation or rehab. That includes physical therapy, modalities, and there are other rehab treatments as well. There are medications, including topicals, and there are commonly used injections, such as corticosteroids and hyaluronic acid. Now, each one of these treatments has its own indications, pros and cons, and data on efficacy, and that's really not something I could get into in this presentation. Next slide, please. So one of the most common questions that my patients ask me is, what about orthobiologics or regenerative procedures? These have evolved in the last 10 years. And if we go around, you'll see a lot of advertisements and banners for curing or regenerating tissue or regenerating tendon or cartilage. And And so I thought it'd be prudent to talk a little bit about the orthobiologics and regenerative procedures. So what is meant by orthobiologics or regenerative procedures? It basically commonly means what we call platelet-rich plasma. That's essentially a blood that's spun down, and we take the platelets, which are supposed to be have a lot of healing factors. And that's the thought behind injecting those back into the body so they can create a healing response. So that's platelet-rich plasma. Then you have what we call BMAC, or bone marrow aspirate concentrate. We have adipose-derived mesenchymal stem cells and placental tissue. So this list goes on and on, but these are the most common biologics or regenerative therapies that are used. And what I would say is they are appropriate when used judiciously. So these really do need to be used judiciously. And the evidence that supports each one of these is still fairly preliminary, is still fairly experimental or poor. And most of the, or most insurances do not cover these procedures. And so that's something that is to be kept in mind. These are usually out of pocket. And some there are some claims that regenerative procedures or orthobiologics, the basic idea behind them is that they can regenerate the tissue. Right now, there is no procedure or medication, unfortunately, that has shown evidence as a disease-modifying agent. What that means is, for example, if you were to take rheumatoid arthritis or some of these other immune-mediated disorders, we have a lot of drugs now on the market that can actually modify the disease. Those are called biologics. So you have drugs in rheumatoid arthritis that can modify the disease or slow its progression. Unfortunately, even if there are claims out there, there is no medication or procedure that can modify the disease activity or has shown to modify disease activity. And that's something that we should keep in mind as we try to choose these procedures. Next slide, please. So I'm a fairly data-driven guy, and so my recommendations usually are based on the data. And I think this doesn't necessarily apply to most academic settings, but there was a warning that was given by the FDA, because if we go out there, and there is a lot of claims, and there are a lot of these treatments that are available out there in terms of regenerative therapies or biologics. And the FDA, this was published in the New England Journal of Medicine, which is one of the premier journals in medicine. They put out a warning that there's a lot of claims on stem cells, and there just isn't enough evidence to support their use in knee osteoarthritis or musculoskeletal issues. So next slide, please. All of this to say that it's not as if they're not indicated and appropriate in certain patients, but really they need to be used judiciously, and the patients need to understand their risks and benefits before they have those treatments. And you really need to get a balanced opinion. And I underline the word trustworthy there. And that trustworthy means different to all of us. And I encourage you to seek advice from a trustworthy professional or a doctor to understand the appropriateness of each one of these procedures. And for sure, our doctors here at UT Southwestern can offer you a balanced and a professional opinion and explain to you the data that supports or refutes each one of these biologics. Next slide, please. So I said that there were a number of challenges, and I'm going to end on a more positive note, which is musculoskeletal disorders are extremely common. However, we don't still understand, we are still scratching the surface of it. We don't still understand why these disorders happen in certain patients. We don't understand why some patients are symptomatic. And for sure, we don't have disease-modifying agents. So we're actually doing a lot of research at UT Southwestern, especially us being an academic medical center. And we have large clinical trials that are funded by federal and quasi-federal agencies such as the NIH. So we are looking at clinical trials comparing treatments. We are actually looking at we're actually going behind where we are saying, well, one of the reasons we cannot figure out disease-modifying agents is because we don't understand the biology. So let's take a step back and understand what are the changes that are happening in the tendon at the molecular and the cellular level, both in the tendon and the cartilage, and that will drive future therapies. So we are doing genetic studies, we are trying to collect tissue samples, we are collecting saliva samples. So if you do visit UT Southwestern, you'll see that you may be asked to participate in one of these studies, some of them being less involved, some of them being more involved. But I'll end on a positive note there. And if you do need more information on these studies, you can go to our website, which is shoulderstudy.org. So you can just Google it and it'll list some of the studies that are ongoing. And with that, I'd like to thank you for your attention. And I believe Dr. Kasitinon is next.
Awesome. Well, great talk, Dr. Jain. So let me pull up my slides. Great. Can everyone see those? Okay, perfect. So, I wanted to just piggyback off of Dr. Jain's presentation, and I'm going to primarily be talking about like a new imaging modality that's becoming more popular within like non-operative sports medicine, and is really kind of changing the game in terms of providing non-operative musculoskeletal and sports medicine care. So my poll question is, what is the best imaging modality to evaluate sports and musculoskeletal injuries?
Okay, it should be on everyone's screen now.
Great. So, from here, I can see that 41% of the audience are really good at taking tests. So usually, if there's an outlier in terms of answers, that's usually the right answer. So really, it does depend. I know traditionally MRI is kind of thought of to be the gold standard, but it really depends on what you're looking for. Just kind of going through these, X-ray is a nice, quick way to look for any type of fracture, like in an acute setting. Ultrasound, which is what I will primarily be talking about, has been gaining popularity, and hopefully the number from 10% will go up after this talk. CT scans are really good if you think someone has a fracture, but then the X-ray doesn't show much. A CT scan is the best at looking at bone itself, and then MRI is kind of traditionally the gold standard for any of the soft tissue injuries, such as rotator cuff issues, knee issues, ligament issues. And then I think depends, to me, is really the right answer, because all these have the right, like in certain situations, they are the best choice in terms of imaging. Great. So anyway, so musculoskeletal ultrasound. So this has really been a game changer in non-operative sports and musculoskeletal medicine. Traditionally, it's thought of to be used in like the OB field or in vascular imaging. Here's a picture of a baby. Here's a picture of some vessels looking maybe for some blood clots in legs. I know the most common joke I get from my patients is, as soon as I slap an ultrasound probe on them, whoever else is in the room, like their family member, significant other, is always like, is it a boy or is it a girl? And it does lighten up the mood quite a bit. But really more recently, over the past couple of decades, it's really gaining traction in all fields of medicine, including orthopedics. So what exactly is ultrasound? So these are sound waves with frequencies higher than the upper audible limit of human hearing. So from 20 hertz to 20 kilohertz, that's what we can hear as humans. If it's below 20 hertz, this is too low a frequency for us to hear, but like elephants can hear them. And then if it's greater than 20 kilohertz, the frequency is a little bit too high for us to detect. However, dolphins and bats kind of use it as like a sonar, and they use it to track things. And then what specifically is musculoskeletal ultrasound? So this is using these high frequency sound waves to create images of soft tissue and bony surfaces. Basically, these probes are made of like crystals, and they send down ultrasound waves down to the structures, and based on the density of the structures, they bounce back in a certain way and create the images that we see. These images are actually in really, really good detail. They're sub-millimeter images. And surprisingly, for superficial structures, they actually have better spatial resolution than MRI does. So at 10 megahertz, the resolution on an ultrasound is 150 microns, while on an MRI, it's 450 microns. So these are some of the real good advantages of musculoskeletal ultrasound. The first is the fact that you have the ability to image in real time. Things like X-ray, CT, MRI. Typically, you go into like a radiology suite and you get the image done, and then a radiologist interprets it, and then later on, then you talk to your physician about it. But ultrasound is something that we do in office, and we talk to you while we're doing it. It also gives us the ability to guide interventional procedures to make sure that we're injecting the medication in the exact correct spot. And it also allows interaction with patient during imaging. One of the most useful things that we do with the ultrasound is called sonopalpation, where essentially I ask you where exactly it hurts, and then you point, and then I stick that probe on there, and we see what exactly is sitting underneath your skin there. There's also minimal metal artifact. We can also use a contralateral limb or other limb to use it as a control, because not everyone's anatomy is the same. So sometimes we can compare side to side. Another really important thing is that it's portable. So over time, it's becoming more and more portable. For example, in our clinics, we have these large machines with very good resolution, but there are also options of these like small probes that, I have a probe that I can connect to my cell phone or iPad and use that for sideline coverage so that, if anything big happens on the sideline, I can definitely have that at my fingertips. It's also relatively inexpensive, and there's no radiation involved with ultrasound. And finally, there really are no contraindications in terms of like medical comorbidities that keep us from using the ultrasound machine. And then in terms of disadvantages to musculoskeletal ultrasound, the first is that there's a limited field of view. Your little, your transducer is only so big, and you can only see within that field of view. So because of that, sometimes you can get an incomplete evaluation of bones and joints. Also, there's limited penetration. Once you hit something solid like bone, it doesn't see anything underneath the bone. So it's hard to see really, really deep structures. And then this is probably the most important disadvantage, is the fact that it's operator dependent. As ultrasound's becoming more and more popular, everyone claims that they are very good at ultrasound, but it really does vary based on different training and different credentials. So, in terms of sensitivity and specificity of diagnosing with ultrasound, and also using the ultrasound to do injections, can be really operator dependent. There are some evolving certifications or accreditations, but there's not really one big standard. Like a lot of people are just doing the training on their own, and really it's hard to tell. One of the biggest, certifications out there is something called RMSK, which is the Registered Musculoskeletal Ultrasound Certification. At least from that, that the person has taken a test and passed it, but there's still really no live portion of that. I know our national organization, AAPM&R, has an ultrasound step course that does have some live testing. So that's another way to try to see if your provider has, had good experience. And also in most sports medicine fellowships or musculoskeletal fellowships, there's extensive training through that as well. And then some other disadvantages, you have to first pay the upfront equipment cost of the ultrasound machine, and there's really variable quality in terms of different ultrasound machines. And the last thing is, it does take a good amount of time in a busy clinic. So overall, it can decrease productivity for the physician. But I think in terms of patient care, it's really worth it to have that available. Right. So applications of musculoskeletal ultrasound, the first is really diagnostics. So I'll go into diagnostics and interventional musculoskeletal ultrasound. For diagnostics, you can really look at all these different structures, and the ultrasound is very helpful. So here, tendons are probably the most common. I know we were talking about, like, a lot of Dr. Jain's research is about rotator cuff. So oftentimes we can evaluate rotator cuffs. The example of the picture I have here is actually not a rotator cuff. It's an Achilles tendon, but that's also something that is commonly, hurts a lot of different people. So here on the right side, you can see this is the Achilles tendon coming across. It looks like a very fibrillar structure and attaches to the heel right here. This picture outlines that for you, and the heel is called the calcaneus officially. And then sometimes we can see tendinopathy or degenerative tendon using the ultrasound. And that way you don't have to necessarily go in and get an MRI for this. You can see the tendon is thickened here. You also have some irregularities around the bone, and that's really indications that someone has, degenerative tendon. You can also look for strains in tendons. Additionally, for muscles, you can look for strains as well as bruises. Tennis calf is a very common thing where people basically just pull their calf. And then this is an example of being able to compare side to side. So on this patient, on the left side, the gastroc is just one of your big calf muscles. You can see that this looks very normal, very linear, and looks just very, I guess, homogeneous. And then here it looks kind of wavy, and this is evidence of a calf strain. And then also if someone has a big bruise, sometimes you can see like a hematoma or a collection of blood within the muscle. And then also you can look at different nerves, pretty much any nerve on the body you can find with the ultrasound. One of the most common ones is the median nerve, which causes carpal tunnel syndrome, which I think is very commonly known in the public. Traditionally, we had diagnosed carpal tunnel syndrome with a nerve conduction study where we shock different nerves and see how they're working. But there's more and more literature about looking at it under ultrasound and really measuring the cross-sectional area. And if you fit certain criteria, specifically if it's like bigger or enlarged and it's greater than 12 millimeters squared, that's also diagnostic of carpal tunnel syndrome. Additionally, you can get a good look at different ligaments and try to diagnose sprains. For knee injuries, the MCL or medial collateral ligament is probably the most commonly injured ligament. And oftentimes we can take a look under ultrasound and see if it's like actually torn or if it's more just kind of a strain pattern. So on this person, you have a little bit, so the normal ligament should be white and just kind of linear. You can see these like areas of a little bit more darkness. So that's area of evidence of a strain pattern or sprain pattern. Also, we can look for any kind of additional joint fluid. So here's a picture of a knee. Black is always fluid under ultrasound. So this person has either bad arthritis or some sort of underlying injury that caused their knee to become super swollen. Also, more and more, we're starting to use it for fractures. Specifically, rib fractures are very well detected by ultrasound. So if someone falls off a bike and hits their ribs and has pain, you can often slap an ultrasound probe on there. Usually you should not have this line there. It should just be like a continuous bright line that's your bone. But here you can see a rib fracture right there. And then lastly, in the ER, they often do something called a FAST scan, which is looking for free fluid in the abdomen for any sort of like abdominal bleeding. And then now that we have portable ultrasounds, we can often do that on the sidelines after someone gets hit in football. It's a very good evaluative tool. So here you can see like this person was hit, and then here's their right kidney, here's the liver. There shouldn't be any fluid in between, but this person does have fluid in between. So you immediately send them to the ER. And then lastly, you can look for something called a pneumothorax or a collapsed lung. Usually it should look like a sandy beach like this. But then here, this is what we call the barcode sign, which means the lung is collapsed, and, also a bad sign. And there have been a lot of studies that show that, the ultrasound is actually more sensitive than a chest x-ray to see a pneumothorax. Interventional, this is probably like the sexier part of musculoskeletal ultrasound. So this is using the ultrasound to guide different injections and different procedures. I know Dr. Jain earlier was saying he was doing a bunch of hip injections today. And the hip is one of the most common things that we inject. So here you can see this is the femoral head or the ball of the hip joint, and this guy is a socket. And then this is the capsule that overlies the whole hip joint. So you can see the needle coming down in the point right there, and we inject the medication in there and it flows into the joint. This is like a far cry from, I think, back in the day when they just kind of stuck the needle in there hoping that it goes into the hip joint. So at least we always know that's going into the right place here. Also, these are especially important when you're doing injections with like PRP, Botox, and biologics, because a lot of times these procedures cost a good amount of money. So if you're going to get them done, you might as well make sure that they're getting put in the right place. Also, we have like peritendinous injections, which are injections around a tendon. One of the most common ones is for tennis elbow, which is really a tendon issue of your common extensor tendon. Here's a picture of this being the common extensor coming around, and you see this shiny bright line coming across. That's the needle injecting the medication into the tendon where the tears are, as well as I typically spread it across the top of the tendon as well. A couple of like kind of more esoteric things. There's something called tendon scraping. It's usually used for the Achilles tendon, where we're basically just scraping where the nerve endings are of the Achilles tendon to try to help with pain. There's also nerve hydrodissections where for mild or moderate carpal tunnel syndrome, there's some pretty good literature out there that instead of having to get a carpal tunnel release where you actually cut the ligament on top of the carpal tunnel, you can just inject in like basically put fluid around here to release the adhesions, and that helps with carpal tunnel syndrome. And lastly, hydrodistension is just a fancy term in terms of of saying that we're putting a bunch of fluid into a shoulder, and that's usually done for frozen shoulder. You can also use ultrasound to do tenotomy, which is taking a thick needle and sticking that tendon a couple of times to try to cause a healing response. Another thing is called aspiration and lavage. This is it illustrated right here. So some people get a lot of calcium deposits within their tendon, and that can be very painful. And with an ultrasound, we can locate the calcium deposit, take the needle, put it straight into the middle of the calcium deposit, and then we inject a bunch of like lidocaine and saline to really break up the calcium deposits and then suck it back out. And then also there's a newer procedure called like 10X and 10Jet. This is essentially the same thing as an aspiration and lavage. However, this device does it for us where it shoots saline into that region and then sucks whatever is loose back out. So you can use this for calcifications or just for for tendinopathy and taking out that frayed tendon. Kind of some of the most advanced procedures that are done under ultrasound guidance now. One of them includes a carpal tunnel release. I know this is still a little controversial, so we don't do this yet at UT Southwestern. But this is a device that was created by Sonex, and essentially it slips underneath the transverse carpal ligament, which is the roof of the carpal tunnel, and then you inflate these balloons, and then that protects like the vessels and the nerves, and then this blade just cuts that transverse carpal ligament, and then this is all done under ultrasound, and really it just takes one scalpel incision, and then you put a Band-Aid on afterwards, and that's the extent of the procedure. And then I know some of our colleagues at Pitt have done some ultrasound guided. ATFL is the most commonly injured ligament in the ankle, and they've been doing repairs under ultrasound guidance of that structure. And then, I just wanted to give a couple bonus things. Number one is shockwave. This we do offer at UT Southwestern. It's, been really popular in the sports and musculoskeletal world in Europe for a long time, but for some reason it just never gained traction in the US. So shockwave is essentially sound waves that have certain physical characteristics, including high peak pressures, followed by low tensile energy amplitudes. Really, the positive phase produces direct mechanical forces, whereas the negative phase generates cavitation and gas bubbles that generates a secondary wave of shockwaves. There are two main different types of shockwave. The first is Fox shockwave. This is one that's generated by electrohydraulic, electromagnetic, and piezoelectric devices, and they have higher energy and generate maximal force at a selected depth. EPAT, or radial pressure waves, are typically produced by pneumatic or ballistic devices, and these are lower energy and generate their highest pressure at the skin surface. They both kind of are used in combination typically, and they have their own merits. One of the good things is that they're FDA cleared. These are non-invasive with very little downtime, and it's primarily used for different tendon issues such as rotator cuff issues, Achilles issues, as well as plantar fasciitis. And really the only contraindications are malignancy and DVT. And I think Dr. Jain had touched upon these. These are both treatments that are used for kind of advanced osteoarthritis and for patients who typically are really trying to avoid the knee replacement or hip replacement. And they're both FDA approved. I think Dr. Jain made a very good point in saying that there's no literature out there that shows that this regrows cartilage, but there are some studies out there that show that it decreases pain and creates a healthy environment for the joint. And I know the adipose cells are offered at UT Southwestern. I don't think anyone here is doing BMAC yet. Otherwise, and the key thing, I think Dr. Jain's last slide in terms of, make sure that you're getting a trusted opinion in terms of doing these is very important, because most of these are not covered by insurance, like these newer technologies, and then they can be quite pricey. So as you can see, when there's any sort of financial incentive, you really want to get a professional opinion that is pretty neutral and has your best interest in mind. All right. So that is all my slides. So it looks like we have about 10 minutes for questions. I'll stop sharing my screen.
Thank you, Dr. Jain and Dr. Kasitinon, for your presentations. We will now begin the Q&A portion of this program, starting with several questions submitted in advance by registrants before going to questions in the chat. So the first one is for Dr. Jain. Are joint issues due to osteoarthritis eligible for those new non-surgical treatments?
The answer is yes, they are. So again, knee osteoarthritis is a degenerative disorder, and part of the pathology is the lack of cartilage. So some of these newer treatments do aim at knee osteoarthritis as well.
Thank you. This next question is for Dr. Kasitinon.
Charlie, okay, there you go.
Does the age and fitness of the patient contribute to the benefits of non-surgical treatments?
I mean, this is a great question. I think no matter the age and no matter the level of fitness, everyone would benefit from some of these non-surgical treatments. But in terms of how to differentiate which one will benefit who the most, I do have that in my decision making. For example, a younger athlete with great cartilage, I typically shy away from doing steroid injections even on the initial visit, because steroid does wear away cartilage over time. So I would steer them more toward gel injections or PRP injections. But for someone who already has known osteoarthritis and is really looking for pain relief, I would be more okay doing a steroid injection, knowing that, there already is some cartilage wear and tear. And, the end destination in terms of structurally would be a joint replacement anyways.
Thank you. Our next question is from a member of the audience. I know I'm going to mess this up, but Shridevi. And the question is, how do you differentiate muscular pain caused by strains and other medications from others?
I'm sorry, who was the question for, Charlie?
It wasn't specific, so I'll leave it open for both of you to answer if you would like.
The question is medications like statin, or how do you differentiate the pain that is caused because of the medication? So in which case the treatment would be different, or by other causes. That was the question.
Sure, that's an excellent question. So in terms of statins, they are known to cause muscular pains, and that's as a result of, in simple terms, it causes muscle dissolution. So there are some lab tests like your CPK, which is a product once your muscle starts, in quotes, dissolving, that will be higher. So that's the way that we differentiate muscle aches that are as a result of statins.
Dr. Kasitinon, do you have anything that you would like to add?
I guess no, I think Dr. Jain did a great job answering that. The only other thing I'd probably add is, like, a lot of times if you just stop the statin and then if you get better, then that will give us the answer as well.
Okay, thank you. So the next question is for you, Dr. Kasitinon. It's from Jim. And can ultrasound be used for C6-7 left side radiculopathy or L4-5S1 degeneration diagnosis?
Hey, Jim. So, I would say to diagnose those, I don't think the ultrasound is good at diagnosing those, because around that area, remember, one of the limitations is once you hit bone, you don't see what's underneath it. So once we hit that spinous process, we can't really see the nerve itself. And then even, I know there's some people out there doing some ultrasound guided spine injections. That's becoming a newer thing. I definitely do not do that. And I think that's still kind of in the early stages.
Thank you. This next question is for Dr. Jain, and this is from Joanne. Is Ehlers-Danlos ever considered as a possible underlying cause of degenerative damage?
Yeah, so that's a great question. And I've seen several patients with Ehlers-Danlos syndrome. I would say Obviously, Ehlers-Danlos syndrome is a connective tissue disorder, as we call it. So it's closely related to our musculoskeletal system. The way I see it is, it is in some ways a precipitating or a predisposing condition that will lead to a higher propensity for musculoskeletal disorders. So patients with Ehlers-Danlos syndrome tend to have a higher number of musculoskeletal disorders.
Thank you. I'm going to go back to some of our pre-submitted questions. And this question is for you, Dr. Jain. Other than physical therapy, how can one relieve pain from old compression fractures of the lower thoracic vertebrae?
Yeah, so that's a great question. So for compression fractures of the vertebral column, as we refer them to, usually bracing is very helpful, especially in the early stages. And beyond that, most of these fractures actually do pretty well, especially if they are compression fractures with just non-operative management. The real goal of physical therapy there is to get you moving, get you back to your baseline functional status. There are clearly other considerations in mind if one does have a compression fracture, making sure you have a bone density test. There's something that led to that fragility fracture. So that really becomes more important is, what's really the underlying condition and how can we prevent them in the future?
Thank you. Dr. Kasitinon, as a former competitive athlete, you may have extra insights on this next question. Can you touch on intervention treatments for throwing injuries in baseball players as far as like pitching for kids and teens?
Yeah, I would say, a lot of these injection stuff, I wouldn't necessarily recommend, especially in kids and also teens for the most part. We see like different injuries. So with kids and teens, they typically, their growth plates aren't closed. So when people have elbow pain, like pitchers, usually in adults, we see it more in their ligaments or their tendons. In kids, we always worry about their actual bones because sometimes with that growth plate not closed, it can kind of, peel off. It can result in a fracture. So with kids and teens, I'm typically very cautious. I always get like an MRI. And if it does show that there's an injury at the growth plate, really it's all about kind of shutting it down and letting it rest and heal. And then once we feel that the bone's healed, then they get into rehab. But a lot of these interventional stuff, I wouldn't, really jump to for kids and teens.
Thank you. Dr. Kasitinon, this next question is for you also. If relevant, could you please comment as to whether these newer techniques work to heal tendon injuries?
I would say most of these are targeted at tendon injuries, specifically chronic tendon injuries, because the whole idea of like orthobiologic, like PRP, shockwave and all that is really when something is stuck in like this chronic phase, you really want to give it a jolt to help the tendon remodel. So that's the whole idea behind that.
Thank you. So that was our last question for the evening.
No. Let's do a couple more because we have time because of our tech issues to go just a couple minutes. We have one from Hope in the chat if you want to get that one. If y'all are okay, if everyone's okay, stick with us.
Okay, so our next question is from Hope Wharton. Treatment for rotary cuff non-surgery procedures. Are there any studies related to these procedures?
So probably a lot of the studies on non-surgical. So there's a lot of data on rehab or physical therapy in patients with rotator cuff tears. In fact, we show a lot of good success with physical therapy in patients with non-traumatic rotator cuff tears. In terms of other procedures such as injections, as well as orthobiologics, I think rotator cuff tears is still, one of those areas that has some data that is available. Again, from the biologic standpoint, it would really depend. There's many factors that play play a role there about their appropriateness, such as the configuration of the tear, the size of the tear, both the anatomy as well as the the substrate or the patient itself. But yeah, there's a fair amount of data on non-operative treatment of rotator cuff tears.
Thank you. Dr. Jain, this next question is for you also. Do you see patients having luck with stem cell injections at the joints?
So, in some ways, the concept remains the same, whether the biologics, or in this case, stem cells, are injected in the tendon or in the joint. The eventual idea is for them to help with a healing response, be it in the tendon or be it in the cartilage itself. So, I think these are still, in my mind, there is still lack of data or evidence or strong evidence that supports any of these therapies. Now, having said that, as I'd mentioned before, I think it's really based on, I think it's very important for you to get an opinion that's particular to your condition. So that's where the whole idea of seeking care from a trustworthy provider comes in. But I would say these treatments still don't have a whole lot of data.
Thank you. Our next question is from Joanne. What can be done for continuing pain a couple of years after surgery for a ruptured Achilles?
Yeah. Yes. I mean, initially, I'd probably take a look at it under ultrasound and see what exactly it looks like. And then that kind of guides things. There are a lot of different options. If you're really just looking for pain relief, we can inject high volume injectate underneath the Achilles and do part of that tendon scraping to kind of, get those nerve endings away. But then, under the ultrasound, if I see that you just have thickened tendon, like degenerative tendon, then sometimes shockwave would probably be the best indication. If you actually have some significant like tears within the tendon as well, then PRP tends to do the best with that.
Thank you. One more question. I recently had SI fusion surgery. Not me, this is an actual question. What can I expect as an outcome? And that's open for either doctor to answer.
Dr. Jain, do you have any strong thoughts, or I have a couple of thoughts about it?
Yeah, you go ahead.
I guess I've, SI joint fusion surgeries, I think those are usually kind of last resort. So I'm sure you had tried some other treatments at the time, but the SI joint fusion surgeries in general, you really have to just kind of wait and see. And be careful in terms of like, sometimes it can alter the biomechanics of the rest of your body. So make sure that you're not developing pain in other parts of your body as well.
Okay, so I'm going to open it up just for 2 minutes. Dr. Kasitinon and Dr. Jain, do you have any last words or any last advice that you would like to leave with our attendees tonight?
Well, we appreciate the engaged audience. It was a pleasure to be here, and it was really great to engage with this audience, and thank you for organizing this.
I concur.
Y'all are terrific. I'm gonna bend your ear about plantar fasciitis when we hang up from here, but let me get back to my script and just say thank you everyone for sticking with us, especially because sometimes when you're live, as we said on TV or Zoom, you don't always have technology cooperate. So thanks for sticking with us. We appreciate all of your really good questions. And as I mentioned in the chat, my slightly torn rotator cuff is of interest tonight with your topic. So I'm hoping to stick with non-surgical intervention. Charlie, you're so awesome at questions. Thank you for helping with that. Julie Kircham, Lori Enright, and the OBI team, we appreciate all that you do to help support Science Cafe. To all of our guests, we're taking a break for the holidays and we will be back in January. Please be on the lookout for a December survey about Science Cafe because we welcome your input and your feedback. And for now, we wish you a wonderful, safe, and blessed Thanksgiving holiday. We wish each of you good health and wellness and a very good night. And we are adjourned. Thank you.